The issue really is that diabetes has become really the major problem in the United States. It is really the major cause why people end up with kidney failure. It accounts for about 60% of the cardiovascular disease, and it really is the cause of most blindness in adults. And therefore, the issue is, do you wait until patients really develop these catastrophic complications, which are phenomenally expensive? The United States, it cost, I guess last year or the year before, $170 billion in direct and indirect costs to take care of people with diabetes. Now, as you've heard, there's an epidemic of diabetes. I mean, I'm a little older. I can remember when we had 5 million people with diabetes in the United States. Now we have 24 million. And so the rate of increase is phenomenal. If you think about what this means in terms of both the healthcare system, the number of people who are going to require very complicated medical treatments, and the cost, we cannot afford to allow this to happen. So what we have done is to understand that diabetes starts at an earlier stage, something we call prediabetes, which you've heard about. And so the question really arises, should you wait for pre-diabetic patients to develop diabetes and the complications, or should you now take a preventive approach and say, gee, it'll cost maybe a lot of money to develop lifestyle programs in the communities, but in the long run we will save trillions of dollars in healthcare. And that's why this is so important, because most people have sort of said, well, pre-diabetes, these people don't have any disease, so why worry about them? But the fact is, if you look at their laboratory tests, you look at their blood sugar, they really have all of these risk factors, which are early, but they are going to progress. And so the whole basis of this conference was to say, how do we identify these people? How do we develop strategies to prevent them from going ahead and developing these catastrophic? And so it's very important that the message that prediabetes is not something that people don't have any problems with. Sure, they don't have any problems when they're 30, but when they're 50, they've had their heart attack, and now they have, an ulcer on the foot. And so that's really the issue that we try to address. And those 6 questions, you can see, really address most of those things. Thank you.
All right, Howard, thank you. And really that was a major point of our conference, to be really thinking how to front load in terms of getting people early and being aggressive early on, as opposed to waiting until people have significant complications, when data from important trials just this year has shown us that that may be not only too late, it may be futile. It may even hurt people if we're very aggressive later on. All right, so now any questions? I'll sit down and we'll address as a group. There's a microphone.
Let me just point out one thing. Harold's right with regard to diabetes-related complications, but remember, this is also a state of increased cardiovascular risk. It is not benign from that regard. It is a matter of some considerable concern to the cardiology community. And that's why we had 2 cardiologists participating in the writing committee, although unfortunately they couldn't be with us today. These people are viewed as having nearly the same risk as patients with established diabetes in terms of cardiovascular risk equivalence. And so it seems that this is a disease entity, prediabetes if you will, which must be identified not only in terms of the future prevention of complications, but in terms of dealing with issues of immediate concern to those individuals right now. Yes, ma'am.
Hi, I'm Tracy Potts with NBC, and I'm wondering, you made the statement that you're not really trying to create an entirely new category of illness here, but I wonder, given the complications that you have with patients carrying out a doctor's instructions when you're told, well, you don't really have this disease, we just kind of want to watch for it. And I know that's a big challenge for doctors in trying to get that compliance. And B, with insurers not really wanting to pay for, I was just talking to a patient the other day who had this issue, not really wanting to pay for medications and therapies and strategies for people who don't have a label. I wonder if there was discussion of that and why you sort of came down on the side of not necessarily wanting to create a label for this.
Well, this label already existed, but you're absolutely correct. On the other hand, you have to remember, if some of those risks are nearly equivalent to being diabetic, and we diagnose diabetes at earlier and earlier stages, you effectively double the diabetic population or more. You are labeling people with diabetes, which may be a far greater stigma than labeling people with prediabetes in terms of insurability or future health care. And it may be that the overall profile of risk is not quite as great as in the diabetic population. And so this has actually been looked at in the hypertension arena by the Joint National Commission, and they labeled an antecedent state of mildly elevated blood pressures as prehypertension. So this is not unprecedented.
Just to speak to that. So I appreciate that you picked up the sensitivity to what does it actually mean in the practical day-to-day life of being a patient, being a physician. So part of what we hope to do with consensus conferences like this is actually to raise that awareness. We're not a policy-setting body, obviously. We just want to look at the evidence, the data, for being more aggressive, being more thoughtful. And it doesn't always mean drugs. It doesn't always mean a label, but almost always means being aware and being alert and being attentive. It's very easy to ignore this completely. And I think there's a big difference between being blissfully ignorant, as it were, but getting sick, versus being alerted. The doctor alerts the person, the family, hopefully. There's a closer follow-up. There's a careful look at blood pressure, cholesterol. There's a recognition that this is a person at risk without quite the implications of being diabetic in the full sense. So I know that there's a nuance here, and you're absolutely right, that insurers have not been helpful at this point. But it's up to us to educate them and get them to be helpful. So that's part of our job together.
Hi, I'm Heidi Sleet with Clinical Endocrinology News. Thank you for all your hard work on this. This sort of follows along with the last question a little bit. Could you elaborate a little bit on where endocrinologists will fall in the equation of actually treating and managing and following some of these patients? Or are these recommendations more for primary care physicians saying, be sure to follow these people and encourage them to take some of these preventive steps? Or at what point do you say, okay, an endocrinologist should be managing some of these things with you?
The majority of patients with type 2 diabetes are already managed by primary care physicians. The number of so-called pre-diabetic patients is almost triple the number of diabetic patients. That outstrips the capabilities of the endocrine community, and frankly, we're not going to recognize them unless they're the immediate offspring or close family relatives of our existing patient population. It's those individuals in the primary care arena who are most likely to see these patients initially. Perhaps it's an obstetrician, a gynecologist who sees a woman with polycystic ovary syndrome who's at increased risk for diabetes, or perhaps it's a hypertension specialist. It's increasingly the cardiologists who recognize newly diagnosed diabetes in patients having their first myocardial infarction. And so it's a large number of other medical specialties. It's probably not us, but since we deal with this both on a research level as well as a clinical level, it's up to us to bring this to your attention and to the attention of the medical community as a whole. Dr. Handelsman, do you want to elaborate on that?
Yeah, I think this is very important to recognize. Even though as a society we obviously have our members at heart, but as a group of experts in the field of diabetes and metabolism, we think that we have a message that we need to bring to the entire health care system. This is not just the physician. This is not just the primary care physicians. We stress so much about lifestyle changes that needs to be done in this country. This is a global problem, as you know. This is the obesity problem. We have now 78% of people above the age 25 are either overweight or obese. Most doctors in their offices don't know even how to take care of them. So that's why we call, at least in some of the areas, we said we'll assist in any national and local community in creating and putting in forth some good tools that we have for lifestyle changes and modification. So we are just the one that would like to bring the message, and as an organization, look at ourselves as kind of leaders in education metabolism. Before we'll take the next question, Dr. Horton, you wanted to say something?